speaker. That is Professor Theo Ruers, and he's speaking about surgery versus radiofrequency ablation, the lesson from the CLOCC trial.
Thank you, Mr. Chairman. Ladies and gentlemen, I have a talk and it's divided in two parts. The first part will be the results of the CLOCC study. And that will learn you something about whether a radiofrequency is a meaningful option for unresectable colorectal liver metastasis. And the second part will be about lessons learned from the CLOCC study. And this will focus on what the local control rate is after radiofrequency in an open setting, so in a surgical setting. But let's first go to the initial part, that's the CLOCC study. And the CLOCC study is about unresectable liver mets, so bilobal disease depicted here as marbles in a sponge on two sides. And the aim of the study, of the CLOCC study, was to go for and determine the safety and the efficacy of radiofrequency ablation in combination with systemic therapy versus systemic therapy alone in unresectable colorectal liver mets. So we randomized patients with unresectable colorectal liver metastasis between radiofrequency and systemic therapy, and also probably the option of additional resection of larger lesions versus systemic therapy alone. Eligibility criteria were unresectable liver metastasis, defined as no possibility to radically resect all tumor lesions. The number of lesions should be less than 10 in the liver. The maximum diameter of the lesions to be treated by radiofrequency should be less than 4 centimeters. And that's because if you treat larger lesions, radiofrequency becomes less efficient. And there should be no extrahepatic disease. The primary objective of the study was to demonstrate a 30 months overall survival of more than 38% in the radiofrequency plus systemic therapy arm. Secondary objectives were progression-free survival, overall survival, health-related quality of life, and safety. The sample size was 152 patients. It was a randomized phase II study, but the study was closed earlier because we had some problems in accrual. And at that stage, we had about 80% of the patients included. Treatment schedules. In the experimental arm, radiofrequency was combined with systemic therapy, and radiofrequency was all performed during laparotomy. Sometimes during laparoscopy, but 90% was performed during laparotomy. In the control arm, systemic therapy for 6 months, and systemic therapy consisted of FOLFOX or FOLFOX bevacizumab during the last years of the study. And systemic treatment was given for 6 months after the treatment. Follow-up was every 3 months, CEA, CT abdomen, and chest X-ray. Patient characteristics were quite comparable between both arms. Most of the median number of lesions was 4 to 5. Most of the lesions were metagenesis liver metastasis. Most of the patients were chemo-naive, and they all had quite good WHO performance status. What about the complications and toxicities in both arms? We see that the complication rate was quite low in the radiofrequency arm. There was one death. That was a patient which was resected and with additional radiofrequency, which had a cardiac arrest a couple of days after the surgical procedure. Toxicity is also comparable between both arms. No large differences between the chemotherapy and the patients who received also radiofrequency. Overall survival, I have to remind you that the primary objective is a 30 months overall survival in the radiofrequency plus chemotherapy arm over the 38%. And you see here that the overall survival at 30 months was 63% in the radiofrequency arm. So that meant that the primary endpoint was reached, but also in the control arm, the overall survival was better than originally estimated. This shows you the survival curves, but be aware of the fact that what we see actually is that the survival curves are separating after 3 or 4 years, but this study was not calculated on a difference in overall survival because the number of patients is far too small to show any difference in overall survival. If we go to progression-free survival, then we see that in the radiofrequency arm, the median progression-free survival is almost 17 months, and in the chemotherapy arm, it's 10 months. So there was a significant difference in progression-free survival in patients treated with radiofrequency. And this difference was statistically significant. What about quality of life? Quality of life was comparable between both groups. What you see is a small dip when patients were performed, when radiofrequency was performed, but after 3 to 6 weeks, they recovered completely, and it was comparable to the arms which received only chemotherapy. So what is the conclusion from the CLOCC study? That radiofrequency plus systemic chemotherapy is safe and significantly improves overall progression-free survival compared to systemic therapy alone, without a significant impact on quality of life. So what can we learn from this study, apart from this conclusion I just mentioned? What we can learn, for example, is what is the control rate of radiofrequency in an open setting? Because now, a question is often used or often asked, is radiofrequency an alternative to surgery? My primary remark is no, it will be not. But I will show you a couple of details where you could probably use radiofrequency in a selected patient group. And the aim of this study was actually to describe the local tumor control after radiofrequency and resection of colorectal liver metastasis. And this was defined to lesions lower than smaller than 4 centimeters, because that's the maximal size for the radiofrequency lesions. And we try to do that in a controlled prospective setting. It's almost impossible to do this in a randomized setting. There's a couple of times there were some examples that it was tried, but they all failed. So the best thing we could do is try to find a couple of studies where we could compare these data in a prospective way. So what we did actually, we used the data from the CLOCC study, and we used the patients in the experimental arm of the CLOCC study. That were 55 patients which indeed are actually treated with radiofrequency. And we used the data from the EPOC study, which were just presented by Bernard Nollanger. And in the EPOC study, patients were resected either without chemotherapy or they were resected with perioperative chemotherapy. And the chemotherapy in the EPOC study was almost comparable to the systemic treatment in the CLOCC study. And we selected patients which had lesions smaller than 4 centimeters. So that meant that from all the patients in the EPOC study, we selected 81 patients who had lesions which were resected smaller than 4 centimeters. The endpoint of this study was the first progression, and local recurrence was defined as the tumor progression as the site of resection or radiofrequency. And all local recurrences were confirmed by the local investigator, so mostly by the local surgeon. Here you see the demography of both groups, and actually it's quite comparable between the patients in the CLOCC study and the patients in the EPOC study, with one huge difference that, of course, in the CLOCC study we are talking about unresectable patients, which means that we have much more lesions than patients in the resectable EPOC study. And it's depicted here, where you see 4 lesions. The median number of lesions in the CLOCC study is 4, versus the median number in the EPOC study, which is 1. Lesions treated, there was a small difference that the lesions located in the CLOCC study were a little bit more centrally located compared to the EPOC study. And the number of chemotherapy cycles was a little bit more in favor of the EPOC study. Patients received more chemotherapy in the CLOCC study. What is the difference? What is the difference in disease progression in this, and especially in local recurrence? If we count the local recurrence after radio in the CLOCC study of the radiofrequency treated lesions on a per patient basis, there were 8 patients which showed a local recurrence, which is 14.5%. And in the EPOC study, 6% get a local recurrence, which is 7.4%. But be aware, patients in the CLOCC study had much more lesions. So if you would count this on a lesion basis, which is much more relevant if you go for the local effect of radiofrequency versus the local effect of resection, you will see that the percentage of lesions that recurred after radiofrequency, these were 10 in 167 lesions which were treated by radiofrequency, which is 6%. And in the EPOC study, 6 out of 110 lesions which were resected got a local recurrence, which is 5.5%. So during open radiofrequency, the local recurrence rate on a lesion basis seems similar between radiofrequency and resection in this patient where the lesions were not larger than 4 centimeters. So the overall conclusion of my talk are that in patients with unresectable colorectal liver metastasis, ablation by radiofrequency results in a prolongation of progression-free survival, which is quite significant, which is 7 months. And for individual lesions up to 4 centimeters, local control after open RFA seems in a similar range as for resection. And what would be the possible consequences of these conclusions? That in patients with unresectable colorectal liver metastasis, local tumor ablation should certainly be considered because it gives you a longer progression-free survival. And in patients with isolated resectable liver lesions, radiofrequency may be considered in a selected patient population instead of resection. And these are high-risk patients with an isolated lesion, and I keep it a little bit more safe than in our study. And I mentioned here smaller than 3 centimeters because the median size of the lesions in our study was 3 centimeters. Thank you for your attention.
Thank you.